The reason for this was that pediatric patients with acute lymphoblastic leukemia do a lot better than adults. And during the most recent decade, many groups have introduced pediatric protocols for patients, adult patients below the age of 45. And if you expose older patients than 45, toxicity will sort of inhibit further approach. So we were interested. The Nordic group for hematological and solid tumors started to involve patients from 18 to 45 years of age in the pediatric protocols. And the reason why children do better, I mean, there are many. It could be the biology, it could be the intensity of treatment, it could be patient adherence and doctor's compliance, among many other things. So we were interested to see if these reports that pediatric protocols for the younger adults really improved survival. So we looked at the United States, this year nine states in the United States, and also the Swedish patients, because the pediatric protocol was started around 2009, and it's called NOFO 2008. But also some other Baltic and other Scandinavian countries included patients. But the main reason for doing this was to see if this change in approach also would have an impact on survival in the general population. And the beauty with relative survival is that you just measure the excess mortality which is associated with the disease itself or its treatment. I mean, you include toxicities and things like that. So that was the aim or the motive to do this. Normally we have looked at almost any hematological malignancy. We have quite nice registers in Sweden and also in the other Nordic countries. So there is, with time, with calendar period, there is some improvement, even though there are no dramatic new drugs. Take acute myeloid leukemia, which is one of the topics in this meeting. For 40 years, there was really nothing new. So when I started off in 1973, we had just had daunorubicin and cytosine arabinoside introduced. But then almost nothing happened in 40 years. But still, there was a gradual improvement in relative survival due to better antifungal treatment, better supportive care and things like that. So, but what we saw, both in the United States and in the Swedish series, we saw a greater improvement in relative survival in patients between 18 and 35 or 18 and 29 and 29 to 45, which was bigger, this increment, than in patients above 45. And there was one difference between the American cohort and the Swedish cohort, and that was that patients up to 84 years of age, the oldest patients, I think they were 32% in the Swedish series and only 25% in the American series. So basically, this improvement, we do believe that this change of treatment protocols for diagnostics, for risk stratification, for treatment has really contributed to the improved survival we see in the young adults. And what the question you should ask is, of course, what's really, how do you explain it? I think it's the introduction of PEG asparaginase, it's the introduction of high-dose methotrexate and 6-mercaptopurine, plus also looking at MRD levels at exact dates, days after induction and so forth.